hello everyone. Today for the first committee interviews, we're going to talk with Dr. Dustin Thomas, who's working at the Parkview Heart Institute, and we are very honored to have him here today. And we were going to talk about reimbursements for cardiovascular CT. So my first question is, why do you think that reimbursement for cardiovascular CT is such an up-to-date topic these days?
Thank you for the opportunity to talk a little bit about this. I think it's a very important topic, like you said. I think the main reason that reimbursement has become so important is that scientists like yourself and others have done such a fantastic job of growing the data set to the point where cardiac CT really, without question, can be considered as one of the single best tests for evaluation of coronary artery disease. Despite the fact that the data is so strong and we have so many prospective data sets showing benefit of cardiac CT, CT really hasn't taken off and grown in the US population as a whole. And I think one of the big reasons behind that is the fact that reimbursement for cardiac CT has lagged significantly behind some of the other diagnostic testing, non-invasive diagnostic testing for coronary artery disease.
Okay. Yeah, like we have indeed so many tests like stress MR or nuclear imaging or stress echo. How do you think that the strength of CT compares to them, and do you think the reimbursement of CT is equal compared with them and in comparison with the information you get of a CT scan?
Yeah, great question. So ultimately, I guess the data would speak for itself, and the fact that I think at a bare minimum we could say that cardiac CT is at least equal to these other testing modalities with respect to the evaluation of coronary disease. You certainly can argue anatomic versus functional, which is better. I think they both are value added in appropriately selected patient populations. When you move over to the reimbursement side of the house, when you look at simply the professional component of the work RVU reimbursement for the clinician reading the exam, CT compares very comparably with some of these other modalities, and in fact is slightly higher than, let's say, SPECT with respect to how well it's reimbursed. But when you look at the technical component side, which is how much essentially the hospital system or the practice gets paid to perform the test, SPECT dwarfs cardiac CT. It's about a four to six times higher reimbursement for SPECT imaging than it is for cardiac CT. And so when you look at it as to how you can support a practice long term and things like that, obviously most practices already own a SPECT camera versus very few practices have a dedicated CT camera or an MR magnet. Most practices own multiple echo machines, and so the accessibility and the revenue stream that comes along with performing SPECT and echo for evaluation of coronary disease significantly favors the use of those two modalities over CT.
Yeah. Oh, I see. I understand that. And what do you think? With these there was a lot of research in cardiovascular CT. We used to only look at non-obstructive or obstructive disease, but now we also have to look at high-risk plaques, and we have to look at the overall burden of coronary artery disease and low attenuation plaque. So that's for sure that's going to take more time for the physician to read the scans. But you get a lot of more information out of that. Do you also think that argues to get a better reimbursement for CT scan than as it is now?
Yeah, absolutely. So obviously, as we start to layer in more complexity in the read for a coronary CT, certainly there's more physician time and effort and potentially risk associated with adding in all those other complex variables when it comes to the additional information that comes out of a CT scan. I think we've known for a long time that there's a lot of data on the cardiac CT scan that we're just not capturing very well in our clinical reads. And you and others, at research institutions are doing a fantastic job really of giving us that data. I think, as you alluded to, as we start to improve the workflows for those kinds of things like total plaque characterization and total plaque volume calculations, where you can more easily assimilate those calculations into a clinical workday where you may be seeing 20 patients and have 10 or 15 scans to read at the end of the day and things like that, as the amount of time required to perform those additional calculations and some of the software that we use to help make those calculations become a little bit more facile and more refined, then I think we're absolutely talking about a situation where reevaluation, through the RUC process or other avenues to readdress, how much physician time is required to perform those scans is absolutely warranted.
Yeah, yeah. So everywhere in the world, stable coronary artery disease is a very expensive disease. What do you think, we've seen the studies now that performing a CT can actually avoid a lot of invasive coronary angiograms, which are more expensive than a CT scan, but other tests can do that maybe too. What do you think that, do you think CT will overall be able, if you use it in stable coronary artery disease, to reduce the overall cost of coronary artery disease?
Yeah, so I think the possibility is absolutely there. I think when you look at the data and how the data has played out in prospective and retrospective analyses, certainly there's the signal there that CT has the capability of reducing cost overall in an episode of care. I think the thing we have to be cognizant of as we grow cardiac CT to the masses is that sometimes utilization of CT in general populations of clinicians across the country outside of some of these centers that have a little bit more expertise and more readers doesn't always mirror the trials. And so I think continuing our educational mission to ensure that we're using CT in the appropriately selected patients, we're using the results of that data appropriately to avoid downstream testing instead of adding downstream testing, and ultimately using it as a means to avoid the cath lab on one hand, but also appropriately select patients for revascularization on the other is right within the wheelhouse of cardiac CT. And I think if we can start to continue to build that message to the general masses, then I think we absolutely have the possibility to lower overall costs with CT. As it plays into the reimbursement argument, obviously, as it currently stands, CT is a much cheaper test to perform than some of these other scans, and so it would make sense that just by virtue of switching a lot of the testing from, let's say SPECT over to cardiac CT would just by itself lower overall cost. However, we also need to keep in mind that at its current rate of reimbursement in many situations, cardiac CT would not be sustainable for practices since it's for the most part fairly undervalued as far as the actual cost it takes to perform the CT scan. And things like that. So I think we need to right size the reimbursement. We're not looking to reimburse way above SPECT or stress MR or things like that. I think we just need to appropriately capture the cost of doing the test and build a model where reimbursement for cardiac CT is sustainable, but will still be less expensive than these other tests.
Mm-hmm. Okay, that's clear. And do you think there is a possibility to perform CTs in the emergency aid, which is a very big, expensive situation too?
Absolutely.
We have seen that it is able to reduce the cost of time in the hospital. Mm-hmm. Do you think there is an opportunity for CT there? Absolutely,
yeah. I think some of the strongest data we have in cardiac CT is in the emergency department setting, and so I think certainly the possibility exists to grow that as a means to defer hospital admissions. Certainly in most hospitals, bed space is at a premium. And so cardiac CT does clearly provide the opportunity to rapidly disposition patients. I think a lot of the data that's come out with respect to partnering cardiac CT with either high sensitivity troponin assays or heart score or other things to better refine the patients that actually would benefit from some additional testing to prevent admission is all promising. And I think there's certainly some barriers to starting a cardiac CT in the ED program, and obviously with respect to coverage from an imaging reader perspective. But I certainly think that the data is strong in that setting of the fact that it can reduce admission to the hospital and hopefully cost. Okay. And one final question, there is also the possibility to first do a CT scan and after that a functional test. How is the reimbursement considering that approach, and do you think that is maybe a way to go? Yeah, I think there's no doubt that when it comes to the battle between anatomy and function, there is a lot of overlap. We know that there's up to 50% of lesions that are greater than 50% stenosis on angiography are not ischemic. While lesser degrees of stenosis can be ischemic and higher degrees of stenosis are non-ischemic. And so there's certainly a role for functional testing in selected patient populations. I think the advantage of anatomy first is for the most part, you know, the initial data for cardiac CT was the fact that it had a very high negative predictive value. So you could effectively exclude disease when it wasn't present. And I think that's still one of the most powerful portions of cardiac CT is the ability to separate the patients that just don't have the disease process from those that do. And then I think that, you know, clinician input as far as the veracity of symptoms that patients present with plays a significant role in appropriately selecting those 10 to 20% of patients that may benefit from additional functional testing, whether that be functional testing with PET or SPECT or treadmill or stress echo or even the application of other CT specific machine learning software packages or CT-FFR or any of these other, you know, novel applications that can help us to serve as a tiebreaker in some of these intermediate patients.
Yeah, in the intermediate patients, yeah. Okay, I think that was very insightful. Thank you very much for this interview.
I really appreciate the time, and I really think that this interview series that you guys have put together is fantastic.
Thank you.